you're ready, just giddy up.
All righty, sounds good. Do we have the screen share capability by chance?
Let me make sure you do. Hang on just a second.
Appreciate it.
Hey.
Need both of you guys need it?
Are you okay with just me having it, Mark?
Sure. It's pretty much your show, but hey, anyway, we want to thank you guys. I'm Marv Rosenberg with Rev Cycle Advisors, and we have the pleasure of knowing folks like Val Barkoff and Ariel and Mike Bickers and a bunch of other folks. And Rev Cycle Advisors has been around for a few years, and we represent a number of niche vendors in the industry that we think have some really neat solutions. And one of those is Velocity Health, which is head up on our 340B pharmacy solution. That's totally contingency based, doesn't require any upfront cost. And the expert behind Velocity on their services that they provide is Leanne Shearer. And I'll let Leanne introduce herself and her background and take you through a quick study of 340B and what Velocity can do to help hospitals that we know are in need, and hospitals we're working with, and how they can add a lot of dollars to their bottom line that they may not be aware of just because of the secret sauce that's been created inside 340B to help prevent hospitals from getting the money they really deserve. So with that, here's Leanne.
I greatly appreciate it, Marv. So if everyone can see my screen, as Marv was saying, we represent Velocity Health. They've been a forefront in the 340B realm for quite some time now, and our goal is just always to continue to expand everything that we can do to help our covered entity partners. A little bit on me. One, that picture was before a small haircut, but it still looks reasonably like me. In Velocity, I serve as their chief pharmacy officer. I am a PharmD by training. I've been a PharmD for about 15 years. I also have my MBA in healthcare administration, and I'm a 340B certified Apexis expert. I've spent my entire career within the nonprofit space, especially within 340B. I'm a national speaker with 340B Health. I serve on their Health and Government Advocacy Board. I'm the chair of the Rural Health Association of Arkansas Legislative Committee, and I also serve as a judiciary subject matter expert for 340B, obviously on the side of the covered entities. I'm actually located down in Arkansas, so please excuse the drawl or any of the y'alls that are going to come out of my mouth, because that's just how I'm wired. So, but we definitely appreciate being able to be here this morning and speak with you guys. So we wanted to start off just a little bit with some background on 340B. I'm sure a lot of this is going to be just kind of a refresher to a lot of the seasoned hospital administrators here. 340B was actually officially born in 1992. It is part of the Veterans Health Care Act. It kind of got known as the title of 340B because officially within that act, it is Section 340B. So most people do refer to it as the 340B program, but you will hear some people that also, will refer to it as the PHS or the Public Health Services Act. How it all began, a little bit further into that, it is managed officially by the Office of Pharmacy Affairs, which is a component of HRSA, also known as the Health Services and Resources Administration. All this does roll up through HHS, which of course is the Health and Human Services branch of the federal government. When the program was initially put together, the verbiage that they used within the Legislative Act was that covered entities were to use the savings to serve millions of low-income citizens. The basic mentality behind it was they wanted these covered entities to be able to save funds on their medication costs, to be able to roll that out under the idea of kind of a safety net provider, or to serve the patients that were uninsured or underinsured. So what does 340B actually mean? The basis of it is this 340B priced medication costs. So kind of the highest tier of cost you'll normally see within the pharmacy realm is called the WAC cost, which is the wholesale acquisition cost. To compare it to kind of non-pharmacy term, this would be dubbed paying full retail cost. Most hospitals, clinics, and other organizations are in some kind of a GPO or group purchasing organization, which does allow them to buy back of that initial WAC cost. So just as kind of a financial comparison, that WAC we consider 100% cost of retail. Your normal GPO contracts get you about 20% back of those full WAC prices. And your normal 340B price is approximately half of those WAC prices. So obviously it's a very large factor in looking at the financials for drug purchases. So this is a very busy slide. I apologize. I just wanted to put everything in there for completeness. So 340B, who qualifies? Number one is that you do have to be a nonprofit organization. Based on that, each one of these bullets represents a different covered entity type. So as you can see, we are up to, I believe it's a total of 23 now. The ones I highlighted in yellow, those are the most common covered entity types that we see. And if you total up those 5 that I have highlighted in yellow, that's actually going to bring you to 87% of the participants in the 340B program. The little graphic I put there in the lower right-hand corner, that's just to signify that when we look at qualifications, there's actually a lot of data that needs to be pulled from a Medicare cost report. They look at things like dish percentages. They're going to look for what lines your provider-based clinics or other outpatient services fall on your Medicare cost report. And they're also going to want to look at the cost report to make sure that you are actually showing dropped outpatient charges. So all of that data comes from the Medicare cost report, and those are numbers that HRSA does look at to qualify your entity. 340B, a lot of times you'll hear people say, what 340B universes do you participate in? So as far as universes, it's just kind of the different fields of 340B that your entity participates in. The number one is just the main covered entity. So commonly this is a hospital, a clinic. It is kind of that main source of truth as to how you were able to enroll within the 340B program. Kind of branching off from that, certain entities do have child sites. So these are sites that are still owned by the covered entity, but do not share the same physical address as the main covered entity. So we will often see this as infusion sites, off-site clinics. Certain times there can even be off-campus OCEDs or emergency departments, and there's a few other ones that also fall into that realm. The important thing is they have a different physical address than the main covered entity. Another universe that has come into play since the inception of 340B are contract pharmacies. This was something that HRSA did stretch the program to include back in 1998. So contract pharmacies officially are retail or specialty or another form of outpatient pharmacy that the covered entity is allowed to go into a contractual relationship with. Once they establish that contractual relationship, they can share their 340B pricing discounts with that pharmacy for patients the pharmacy serves that are also patients of the covered entity. And we'll go through just a little bit more on that because it can get slightly convoluted at times. And then the latest expansion they did, which they officially pushed out back in 2018, it's only gained traction in about the last year and a half, is the closed loop referral program, which added another dimension to the 340B universes. And I'll also talk about that in a little bit more detail and show some graphics. So this one here is a little bit of a schematic that's looking at the contract pharmacy dynamics. So I won't go into it too deep because I'm sure a lot of people already understand that. And I'm more than happy to talk to anybody in more detail later on if that's beneficial. But basically the way that it works is these retail and specialty pharmacies that covered entities can contract with, they are able to share their drug prices only for common patients between the contract pharmacies and the covered entity. The benefit to the contract pharmacies is the covered entity does pay these pharmacies a dispensing fee for being part of this partnership. The discount that is realized from the lower cost medication, that does come back to the covered entity. It does come back in the form of a check or some kind of a direct deposit. So most covered entities do set it up as its own cost center or its own new revenue stream. So that one, it's not actually considered savings. Most people do book it as actual net revenue that is coming in. As far as the expansion within contract pharmacy, HRSA does not limit how many contract pharmacy relationships you can have. So some entities might just decide to include local pharmacies that are very accessible and common use for their patients. There are other covered entities. The largest one right now has over 600 contract pharmacies, just depending on exactly how far you want to spread that umbrella out, but HRSA does not limit you. The next one here, this is the closed loop referral, which has been the latest addition to the program. We see more of this utilized in the rural space, especially with smaller facilities that don't have a lot of their own specialists on site to take care of their patients. So what the closed loop referral dynamic allows people to do is if you have a patient, and I will just kind of start up here. So a patient is seen somewhere within the covered entity, either at the main covered entity site or one of your child sites. For some reason, the covered entity has decided that this patient needs to be seen outside of the facility. So it could be for a higher level of care that is needed if the acuity level of the patient is too high, or most commonly it's if there's some kind of specialist that this patient needs to see that the covered entity just doesn't have the ability to offer that line of care. So at this point, they will put a referral within their EMR or EHR system for this patient to go see, and I'll just use the example of a cardiologist. So they send a referral to the cardiologist, they document it in their EMR. The next step is the patient is going to go see this outside cardiologist, most likely going to receive one or multiple prescriptions depending on their diagnosis. The next step is this referral visit summary, clinic note, summary visit. You'll hear a lot of interchangeable terms in this space, is sent back to the covered entity. And once the covered entity receives it, they upload it into their EMR system with the intent of showing the continuity of care. Once all of these different pieces have gone together and we have closed the loop is the terminology that they use, any of these prescriptions that the cardiologist in this example wrote, the covered entity can actually capture the contract pharmacy revenue from the cardiologist prescription because they were able to close the loop. They were able to show continuity of care, and they were able to establish that even though the patient was seen at the cardiologist, that this patient in theory is owned by the covered entity because they're considered that primary point of care. It does get a bit complicated. There's some policy and procedures that we have put together that have been worked on and blessed through Apexis to make sure that this full cycle is not only transparent, but it is followed through with all of the covered entities. But it can be something that can be a pretty financially impactful expansion of the program. Entities that we've worked with, we've seen everything from a 20% increase in their contract pharmacy revenue to some of the other ones have more than doubled their monthly net contract pharmacy revenue by expanding into this space. With the 340B program, this is usually kind of the part that scares people a little bit. With it being a government mandated and a government oversight program, compliance is of course very, very important. HRSA does have the ability to come in and audit covered entities at any time. The audits are chosen at random for the most part, unless for some reason they do have a suspicion that something might be going on within the covered entity that does go against the standards for 340B. But last year, for example, 94% of them were random audits. If you look at the frequency of the audits, your average covered entity is going to get audited about once every 3.5 years. What we recommend from the compliance side is some internal integrity measures. Number one is just having very detailed policy and procedures that are updated at least once a year, or sometimes more often once we do see some changes to the HRSA guidelines within 340B. So the process is as to how you utilize the program, how you maintain compliance, as well as just clear documentation of your workflow to do so. If you are chosen for a HRSA audit, this is going to be the very first piece of information that they look for, and they do go over these with a pretty fine-tooth comb. We do also recommend ongoing education within the covered entity. HRSA does expect this on at least an annual basis. So kind of the key players, and it does vary depending on the covered entity type, but we always recommend that your pharmacy personnel are educated. Anyone in finance or accounts receivable, accounts payable, anyone that's going to be seeing these funds that are coming into the covered entity. and then C-suite and other senior leaders. Also, when HRSA comes in, they do usually have a point of contact, which is going to be the primary contact that you have registered with them and your authorizing official, but they will ask to speak to other members of your team, most specifically pharmacy leadership, pharmacy buyers, and they will want to talk to senior leadership just to make sure that they understand not only the program in general, but how the specific entity is utilizing the program. Another thing we recommend just to ensure that compliance is monthly audits across all the universes. So from everything that's used within your hospital and or clinics, everything that is being done within the contract pharmacy space. And then of course, if you move into that referral realm, that is something else to keep up on the audits. HRSA officially encourages you to have a third party involved to do some of these auditing. The only way that they mandate that is if you have moved into the contract pharmacy space. HRSA now does require you to have an independent audit at least once a year. If you are audited, they will ask to see proof that you have had that external audit done within the last 12 calendar months. This year, just moving into a few little updates. Obviously, 340B has been going through some changes and had quite a few hurdles that they have had to overcome in the last year. So I was just going to give a slight update of how all that has been looking over the last year. There are now 6 different drug manufacturers. They have been dubbed the shameful 6 of big pharma. I did not make up that term, but I do think it is a pretty good description of what's been going on within the space. So the 6 manufacturers are listed there. It's AstraZeneca, Eli Lilly, Sanofi, Novartis, Amgen, and Novo Nordisk. They have decided, they kind of went in a sequential pattern over the last year, but all 6 have decided that they are no longer going to honor 340B prices within the contract pharmacy space. You will hear a variety of logic from Big Pharma as to why they feel that that is not something that they have to honor within the 340B program. Recently, about 3 months ago, Sanofi did reel in their restrictions just a little bit. They said if you are a pediatric hospital or an FQHC, they did not include FQHC lookalikes, just for full transparency on that. They said they will honor contract pharmacy prices if you are one of those 2 designations. Obviously, there are several lawsuits that are going on right now at the both federal and state levels from different advocacy groups trying to combat this. HRSA and HHS have been relatively silent on the matter so far. They have chimed in a little bit that I think I get to on the next slide. Unfortunately, being a covered entity, there was a Supreme Court case a few years back that designated that as a covered entity, we actually cannot sue Big Pharma over 340B pricing. So that has put a lot of limitations on the covered entity side. So that's why most of that work is being done through advocacy groups. 340B Health happens to be one of the largest ones currently. Another attack we saw on 340B was the implementation of what they call the 340B ESP platform. Rumor has this is backed by Big Pharma. That's never officially been stated. But what the platform was stating is that the platform has requested that as a covered entity, you upload on a weekly basis all of your 340B claims, applying to all of the 340B universes, including patient level, obviously HIPAA grade data. Their intent on this is they wanted to be looking for what they call duplicate discounts, which is its own soapbox and somewhat complicated, but it's basically to make sure that you weren't claiming 340B on Medicaid patients. There was a little bit of pushback because they were asking covered entities to upload all payers instead of just Medicaid. So it kind of broke down the trust on the intention on that one. So far, this has not been pushed through as mandatory, and it has kind of been in a holding pattern since it was initially announced almost a year ago. Another attack that we saw was within the Calderos platform. What Calderos is attempting to do is actually switch 340B from an upfront discount to a retrospective rebate model. So their intention was for covered entities to initially buy all of their medications upfront at WAC pricing, which of course is the highest retail price, which would send drug budgets through the roof at covered entities. To submit claims to Calderos for the ones that you believe are 340B eligible. These claims would then go to Big Pharma, and Big Pharma would be allowed to approve or deny these rebates to get you whole back to that 340B price. Once again, a lot of pushback. It does require HIPAA grade information. I was going to send drug prices for covered entities initially through the roof, and there was very little transparency on Big Pharma's ability to be able to deny claims. They weren't sharing any logic as to what would allow them to do that, and they also weren't sharing a time frame that the covered entities could really expect to get these rebates back. Once again, this one has not been made enforceable. HRSA is very hesitant about it. They said it is a compliant program, but they do not feel that it aligns with the intent of the program. The next step here, I've entitled this one 340B Hope. So the last slide that I just shared with you is obviously very discouraging on the 340B side. There's been a lot of challenges that have come up in the last year. While HHS has been relatively silent on these challenges that we faced within 340B, they did offer a 11-page, I believe, advisory opinion that was released in December of 2020. The advisory opinion, and there's a references slide there, so you can read the entire thing if you would like to, but it was very pro contract pharmacy, and it was definitely encouraging on the covered entity side. Here was just one of the quotes that I put in from their conclusion paragraph of this advisory opinion. It basically states that HHS is taking the stance that contract pharmacy pricing is considered a valid part of the 340B program, and that Big Pharma is obligated to meet their obligations there. With it being an advisory opinion, it is not legally binding. The drug manufacturers, 3 of the 6 I spoke with earlier, did come forth pretty quickly and say they disagreed with the advisory opinion and they were basically going to disregard it. The other 3 manufacturers so far have been silent as far as any response to this. This next one here, I told you I'm from Arkansas, so I had to throw this out because this was something that I was part of that we were pretty proud of. There was a bill, it passed just about 2 weeks ago now, not even 2 weeks ago, that was passed through Arkansas and signed off on by the governor. I've also put the reference in there because it's about a 6-page document that does include more than this point that I have referenced here. It was all very positive towards 340B, but the biggest takeaway from that bill is they actually stated that it is illegal for drug manufacturers not to honor pricing at contract pharmacies. Since Arkansas passed this on April 27th, we have had 2 other states follow suit with very, very similar bills. Indiana went right after Arkansas, and I believe Tennessee was just the day before yesterday. So we did ours here through Arkansas with a partnership through our Arkansas Hospital Association. We have worked with several other states just to share what we're doing, share our reference sources, as well as to share our preliminary documentation. So we are hoping to see more states follow, and we're also hoping this is going to kind of set a new national precedent. So more to come on that part, but it definitely steps in the right direction. So with velocity and everything that I've thrown out at you, as you can tell, it's a very complicated program. There are a lot of compliance risks due to its complexity, but the savings that you can see back to the covered entity can be incredibly substantial. So with velocity, once we started working in this space, we really wanted to present our solution as kind of a concierge white glove service. We have covered entities that we work with that partner with us to the extent that we manage their entire program directly, minus signing off on a few pieces of paperwork that does fall on leadership at the covered entity due to HRSA guidelines. But we come in, we do a full program assessment that's completely complimentary, and our assessment kind of is 2-pronged. We look at it from the compliance side as well as the financial side. So we will let you know if we do see any problems within your program on compliance. And we'll also let you know the financial potential that may be untapped in your program so far. We also take over all of your auditing. So anything that is compliance related, we do all of your audits. We do them all in real time, get the results directly back to you, as well as recommendations to correct any findings we might come across. And we also provide you financial auditing. So as everything continues to get more complex within the 340B program, we really want the covered entity leadership to have full transparency into what's happening on a month-to-month basis, because it can swing pretty widely as far as what your benefits from each of your universes is supplying to you. Another thing we do is audit readiness and support. We offer external audits to all of our clients so they can not only meet that HRSA requirement, but of course know exactly what is going on in their program and any new issues that might have popped up. If you are chosen for a HRSA audit, we also help you with full readiness. It is a pretty sizable data request that you get from HRSA that can be a little complicated to put together at times. So we help support our clients through that. And then we also sit on site right next to you through the HRSA audit to make that process as painless as possible. As you get into more complex pharmacy situations, such as limited distribution networks, which is specifically tied to specialty pharmacies, we help to make sure that you can get access to the medications that your patient population needs, both on the hospital side as well as through your contract pharmacies. We do a lot of work within the contract pharmacy space just to make sure that you are partnered with the right pharmacies to serve your patients. We do a lot of benchmarking as far as those financial contractual terms to ensure that the lion's share of the savings is truly coming back to the contract entity, so we can advise on that part as well. And then of course we come in and work those closed loop referrals for a lot of our clients as well. One, to make sure that they are remaining compliant because it is a more complicated side of the program, and to make sure that all of those referrals that are leaving your facility, we are capturing back all of the revenue that should be designated to the covered entity. Everything we do is on a gain share engagement, so we don't have any upfront costs for any of our services. We also don't require any kind of an IT build. All the work that we do is within your existing EMR platforms. And if you've gone into that contract pharmacy space, access to your third-party administrator platforms. So we do everything behind the scenes. Your providers don't have to change anything in the way that they enter orders or generally take care of their patients. And the patients never even know what's happening. So it's not going to change where they go for care or where they go to get their prescriptions. So we just work within that system that already exists within the covered entity. This is just a little bit of contact information. Marv is also on the call. Marv has been working with Velocity for a long time. He works on the client success and sales side, so there's some information for him. Below that is my contact information. If there's anything I've gone over that you'd like a little bit more of a deep dive into, I'm more than willing to share or go through any of those topics with you. And then this last slide that I put together here, these are just some of the references that I went through in my presentation. The top two here are related to the actual formation of the program. It has a lot of great information, Q&A information, as well as linking you to the bills that actually brought 340B to life. This third one here is referencing that advisory opinion that I talked about that HHS put out. And then this final one is that link to the Arkansas bill that we are really hoping gets the 340B program back on track. So with that being said, I know I threw a lot at you in a very short amount of time. If there's any questions or concerns or anything I could answer for anyone, I'm more than happy to. I am so sorry. I'm having a little trouble hearing you, sir.
Really loud.
Really loud. Okay. All right. Can you hear me now?
That's a little bit better. I think so.
Yeah, go to that camera.
Okay. You're in the pharmaceutical space from 340B perspective, but does your company also help with copay assistance programs and knowledge related to that?
We do. Velocity as a whole. So I'm the 340B arm of the Velocity company, but Velocity as a whole, they do a lot of work with prior authorizations, copay assistance. We have a very great platform that will link with discount cards, different organizations that do charity care, and just kind of getting you in touch with those right people for, some of your patients that are a little bit off kilter from the normal. So we can definitely assist with any of those needs as well. And we do work with all the different TPA systems. We've been in the space for quite some time. Currently, there are 44 different third-party administrators in the market. Out of those 44, we've worked with 42 of them. We have long-standing relationships. So it is something, as far as the complexities of those platforms, we help a lot of our clients, keep those up to date, make sure their NDCs, ERXs, everything are completely current. Just also take that workload off of your internal staff. Marv, was there anything you wanted to add on?
No, just that we're happy to set up as little as 30-minute call to talk individually on what some of the issues you have or some of the things you may not even know are issues. And any pharmacist in the room? Because one thing we do typically find, and I've been on the rev cycle space for the last 35 years. You have this in other areas of the organizations, but one thing you typically hear from the pharmacies is they're doing everything great and there's no room for improvement. And as Leanne pointed out before, typically the upside for our clients is about 20% more than what they're gaining right now from the 340B pharmacy program. So it can be a lot of money to an organization. And I'm not sure who we forward the slide deck to, but we'll get that out and make that available.
Any other questions? Everybody good? I think we can let y'all go now.
Right. It has been a great
Thank
pleasure.
you all.
Enjoy a gorgeous day, and thanks again for having us.
Everybody get home safe.
Thank you.
All right, y'all take care.
Thank you.